more people, I hope, will be able to join for this webinar. I just want to say a few words before we dive in. All of us here connected belong or a member of a network, the Unity Study, specialized for Unity Studies. And we actually have very precious opportunity now in peacetime to develop the capacity needed that will be for the next pandemic. And the protocols being developed. We do have a lot of protocols developed, but at the moment it's a document. How to transform this document into something really helpful, real capacity to support countries, to support the global response to the next pandemic. This is something that the members of the network, we need to invest time in. And now this is a good opportunity because we are in a peacetime. So actually, I'm really grateful for the members. And this time we have colleagues from UKHSA as well as Indian to share their experience of using the protocol in real cases, in real situation. So I hope during their presentations, they could also share their experience, not only adapt the protocol for use, but also maybe to reflect the essential components of a Unity study. For example, ethics clearance, from the ethics clearance from the very beginning, going down to the data sharing. Just do some of the reflection. It will be very helpful to everybody to prepare in their cases. So I hope that this could contribute to activate more this network. And I know this network is a live network, and we want to demonstrate. So this sharing of information and experience from member sides would be super, super helpful. If you have any comments or suggestions how we can coordinate, organize, facilitate, and build this network better, please do let us know. Do let Nikki know, indeed, who have been having her camera on here. So without further ado, I look forward to the experience from UKHSA and India. Back to you, Nikki.
Thank you, Wenjing. I've just got a few slides just to go over a few quick housekeeping slides, and then we'll dive into the rest of the meeting. Thank you, Wenjing. So just in terms of the agenda, thank you, Wenjing, for opening the meeting. Quick few background slides, and then we have, as Wenjing mentioned, we have two sites presenting today. So we have Jamie Bernal-Lopez presenting on implementing the FFX protocol to investigate single influenza avian cases in England. And then we have Farzana Islam from the Hamdard Institute in India talking about exercising the household transmission protocol. Just in terms of housekeeping, please avoid connecting with 2 devices or more so that we prevent any echo. The meeting is being recorded. And if you are able to use the rename function just to add your affiliation and country, that would be most helpful. And please feel free to submit any questions using the Q&A box at the bottom. We do have interpretation available today in Spanish. So to do that, if you can use the interpretation tool at the bottom of your screen and select Spanish. And then you can mute the original audio so that you just hear the Spanish as well. And then just to give a bit of background to the webinar, put it in context with the Unity Studies activities more generally. So you'll all be aware and are members of the network that we launched earlier this year. We currently have 17 sites recruited globally with representation from almost all regions. And as part of being in the network, so sites agree to carry out various duties, both in the inter-pandemic period and the pandemic period. And I won't go through this slide in detail, but I just wanted to highlight that one of the duties during the inter-pandemic period, as Wenjing mentioned, is to prepare themselves for conducting these investigations and studies. And part of this will include exercising one or more of the protocols at least once a year during perhaps a seasonal influenza epidemic, or a respiratory virus outbreak. So, and I hope that we show through this webinar, showcase how 2 of our different sites are approaching this. So without further ado, I'll hand over to Jamie, who will talk about the experiences of using the FFX protocol in England. Thank you, Jamie. Over to you.
Thanks. Let me try and share my slides. Can you see that now?
Not yet, no.
Anything yet?
Got it now. Yeah, thank you.
I got it. Great. Okay. Well, thanks very much for asking me to present. I'm just going to talk a bit about our FFX protocol in England and some of the lessons that we've learned from COVID, how we modified the study since then, and then I'll cover the FFX studies that we've run in 2025 and some of the further lessons learned from these and future developments that we've got planned. So I'm sure everyone's aware of this, but briefly an overview of what FFX is. When a new respiratory pathogen emerges, we typically have limited understanding of the characteristics of that pathogen. And the intention with the FFX study is that it's a case-sustained prospective study of close contacts of the early lab confirmed cases of a novel respiratory pathogen, and it involves an early assessment of the epidemiological, clinical and virological features of that novel pathogen. The intention is that that's done with the first few cases and with a defined set of close contacts of those cases. In the UK, we've run FFX studies before during the H1N1 pandemic, for example, with COVID-19 and also with MERS cases. It's based on the WHO protocol that we're discussing, and the intention is that our protocol closely matches the WHO protocol, but it's obviously adapted to our particular situation within the UK. Our primary objectives are again closely aligned to those of the WHO protocols. So focusing on the clinical presentation and outcomes of the novel pathogen, the symptomatic proportion, the secondary infection rate and secondary clinical attack rate, and the serial interval. We also have secondary objectives that we can sometimes estimate from the FFX. So case or infection severity ratio, such as the case hospitalization ratio, case fatality ratio, infection hospitalization ratio, and infection fatality ratio. Some of the data can also be used to inform estimates of the basic reproduction number, to look at incubation period and duration of viral shedding, and if there are countermeasures in place, to look at the effectiveness of countermeasures. And answering these questions helps to inform things like whether isolation is needed, how long for, whether different NPIs are likely to be needed, and which groups are most likely to transmit. And the idea here is that it will rapidly inform our guidance and policy making. The focus of our FFX studies are on human cases and human-to-human transmission. And they won't provide us with much information on zoonotic transmissions. So the study population to be included in the FFX study, we've decided that this should be agreed by an incident management team. We typically, for a novel pathogen, will develop a case register, and this is used as the sampling frame for the FFX study. And this may include any cases, so all of the cases of the novel respiratory pathogen, or sometimes we may restrict, and I'll come on to this in a bit. We then also include close contacts, and that typically includes household contacts, healthcare worker contacts, and potentially some other close contacts as well. And it's really the contacts that are most of interest in the FFX study. This shows our algorithm for follow-up of cases and contacts through FFX, and as you can see, it's quite an intensive follow-up. So includes baseline and follow-up questionnaires, repeat swabs, in this case every 2 days, and a baseline and convalescent serum sample. We did a big FFX study at the start of the COVID pandemic, and that ran between January and March 2020. This included all confirmed cases and all close contacts. A baseline questionnaire was done at day 1 and then a follow-up at day 14. And the testing that was done as part of the FFX was based on the public health management guidelines at the time. And this only included testing of contacts if they developed symptoms. Because that testing was quite limited, we also then ran a second household transmission study after the FFX study between March 2020 and November 2020. And this was based much more on community cases. So they were initially identified through our primary care surveillance scheme, and then once COVID community testing was in place, through that process as well. Again, a day 1 and day 14 questionnaire, but also added a symptom diary, and contacts were swabbed on day 1 and day 7, and had baseline and convalescent serum samples in this case. And that was repeated again in 2021 to look at the effectiveness of vaccines on transmission. So there were quite a lot of lessons learned from the COVID FFX. Firstly, the model had always relied on health protection teams, so our local teams having the primary responsibility for completing the case and contact questionnaires. But early in the COVID pandemic, their capacity quickly became overwhelmed with the huge number of possible cases that they were risk assessing and managing, many of whom had over 100 contacts that also needed to be managed. So there was fairly limited capacity for them to complete these large questionnaires. There was also limited testing availability, and this testing was mainly directed towards hospitalized cases. So this created 2 issues. It meant that there were few community cases that were identified, and community cases are generally much more useful for informing transmission dynamics assessments. And it also meant that there was limited scope for sequential testing to assess things like duration of viral shedding and to identify asymptomatic cases among the contacts. There was also limited capability for collection of serum samples at the time. Another point early on was that a large proportion of the identified cases were imported, and these are again a bit less informative when you're assessing community transmission. And we also had some issues with the software that we were using being inflexible to adapt. So to add or modify questions was challenging and relied on particular people that were not always available. And that meant that we ended up relying a lot on manual data entry. Where it was more successful was in providing useful early information on clinical presentation and outcomes, and this informed the case definitions and our understanding of the timing from infection to clinical outcomes. We also moved to using a centralized team, which was much more successful, but it does create extra challenges with integration with the public health management of the cases. And then we ran the subsequent household transmission study that was based on community testing, which provided much more useful data on transmission dynamics. We also had great success in using self-sampling approaches, which allowed much more swabbing without having to pull in a huge number of staff to go and see each patient to do that swabbing. So I think the COVID FFX highlighted some of the challenges that I think we'd face with most FFX studies. Firstly, it requires a lot of resources, and it's difficult to operationalize in the context of the need for public health management of cases and contacts at the same time. It needs to be flexible to adapt quickly as we learn more about novel pathogens and new questions emerge that may mean that we need to adapt the questionnaires rapidly. And lastly, the characteristics of early cases are often atypical and can limit our understanding of transmission dynamics. For example, early cases are typically imported, and so the exposure and contact patterns that they have are often atypical for assessing community transmission. And early isolation of cases means there's limited scope to assess their transmission dynamics in a normal environment. So taking each of those in turn, and firstly looking at operationalization. FFX, as I say, is very resource intensive. There are long questionnaires to complete with cases and contacts, and a lot of sampling planned as part of that. This will also happen at a time when there are a lot of competing demands on resources if a new pathogen has emerged. And so the decision to initiate the FFX study needs to be made by an incident management team that also has oversight of those public health management side of things. And it will need to be integrated alongside the public health management of cases and contacts. It will typically be health protection teams that have the initial contact with cases. So rather than having lots of different people asking similar questions of unwell people, it makes sense that they at least do the initial questionnaires, though they will, as we've seen, have limited capacity if there are lots of cases. And so we feel that a central team is also needed to take forward this study to do a lot of the follow-up and study coordination, data management, and the analysis. And finally, the study also requires a lot of testing capacity, including kits and reagents and people to take samples, as well as PPE for these people and lab capacity to test the samples. We developed a new data collection tool for FFX. This uses software called Snap Survey. We've had various different approaches to data collection, but we feel this has quite a lot of advantages. It's a software that's approved by UKHSA, the Public Health Agency, for collection of identifiable data. It can be used within the hospital trusts as well. The data is linked to an SQL database, and it can be modified relatively quickly by the team running the study. It does have disadvantages, though. It's not a dynamic application, so it can't be pre-populated with previous responses, for example, and it doesn't automatically make those links between cases and contacts. It's also not integrated into the usual public health management software that we use in the UK. On the sampling side, this does require significant testing capacity, and that includes kits and reagents, people to take the samples, personal protective equipment, and the laboratory capacity. In our view, healthcare worker taken swabs are likely to be needed initially alongside any self-swabs in order to validate the self-swabbing. We also need phlebotomists to take serum samples, and we need early guidance on transfer of samples, especially if we're moving to a self-swabbing approach, and we need to consider how those swabs would get back to the laboratory. The other consideration is around getting kits out to participants if they're self-isolating, in particular if those samples are going to be self-samples. And that we also need the testing capacity through our national reference lab and or any public health laboratories. In terms of the proposals that came out of COVID for selection of cases and contacts, initially we would include all cases of a novel pathogen, but that may be refined further down in the study, so focusing more on indigenous cases and on community cases that are likely to provide us with more useful information on the transmission dynamics. In terms of the contacts, our focus would be on those with well-defined exposures that will provide the most information on transmission dynamics. And that's the priority there, I think, for us is household contacts. Early on with COVID, we tried to collect data on a huge range of contacts, but it meant that the capacity was used up on collecting data on contacts that didn't necessarily provide us with that useful information on the transmission dynamics. And instead, we would prioritize using separate protocols for studies in other settings, such as in care homes or in schools, for example. Our analysis plan is closely aligned to the WHO analysis plan. We produce regular sit reps on the recruitment and the clinical features, and then slightly less regularly, we would do analyses of transmission dynamics and doing as much pre-coding in advance of this where possible. We also need to think about collaboration. So within the UK, we've got separate public health agencies in England, Scotland, Wales, and Northern Ireland. But the plan is that we would work collaboratively as for the FFX study. So need to think about that data sharing and also data sharing with modelers. So we've got a modeling group that provides advice to government called SPI-M. And we've got new data sharing processes in place with them as well. So moving on to think about the more recent FFX studies that we've run. So we've run FFX now twice this year. The first time was when we identified a human case of H5N1 in January 2025. There obviously is only a single case, and there are limited amount of information that we can draw out for that because it was one case, but it was a useful test of the practicalities of the system, and I'll go through what was done in terms of follow-up and what we found. So firstly, thinking about the index case, as I say, the case was identified in late January 2025, and it was somebody that had been exposed to H5N1 infected birds on a farm. Their symptoms were relatively mild respiratory symptoms, which they recovered from in a few days. They were admitted to a high containment infectious disease unit, but this was for isolation purposes rather than because of disease severity. And they did receive oseltamivir at the hospital and were discharged was that 5 days after their symptom onset. There were 3 household contacts that we followed up. One of them reported fever and a cough with onset 2 days prior to the onset in the case, and there were 2 contacts that reported no symptoms. One of the contacts received oseltamivir and was admitted to the HCID unit, and the other 2 contacts were given oseltamivir in the community and isolated in the community. So this is the follow-up that we did. So from the point that the case was identified, the first swab in the case was positive, but all subsequent swabs were negative. And we took baseline and convalescent serum samples, and there was no evidence of seroconversion even in the case. All of the cases and contacts had the baseline questionnaire and the follow-up questionnaire completed. With the contacts, they each had 4 swabs, all of which were negative, and similarly, there was no evidence of seroconversion in the contacts. So the conclusions from this analysis were that we saw a mild illness in the index case, limited duration of viral shedding, and no evidence of seroconversion in the index case. We saw no evidence of transmission to household contacts, and as it was a single case, we had limited information that could be drawn from the FFX on disease severity or transmission dynamics. Then the second time that we've used FFX, in fact, we're in the middle of it right now through an exercise. So we are currently running a cross-government pandemic exercise, which has a novel simulated enterovirus. And we have been exercising FFX as part of this. So it was a novel enterovirus that was detected in Southeast Asia with a respiratory illness and symptoms of acute flaccid myelitis. We then had cases detected in the UK from early September of 2025, and you can see the epi curve here at the bottom. And so it's primarily sporadic cases that have been identified, but the lighter colour indicates those that were cases that were identified as contacts of those sporadic cases. We had a data set that came through as part of this. It didn't exactly follow what we had within the FFX protocol, but allowed us to do some testing of the analysis plan. So this here is looking at the cases that are identified from contacts. We didn't refer to them as secondary cases because in some cases the onset date in the contacts was earlier than the onset date in the index case. So here you can see the proportion that were symptomatic and proportion that had AFP, and in fact none of the contacts had acute flaccid paralysis, and approximately 30% were asymptomatic. And this is looking at the severity indicators among the contacts. So we had 65% of whom were hospitalized, and one of the cases was admitted to ICU, and 2 cases died. And this is the early look at the transmission dynamics. So there were 2. Initially, we just had data on testing for this novel pathogen, and that gives you a pretty low secondary attack rate, around 2%. Then we received another data inject that includes pan-entero testing. And although earlier on for some of the other data injects as part of this incident, pan-entero wasn't necessarily that useful because we also had rhinovirus supposedly circulating at the same time, and that we couldn't distinguish between the novel enterovirus and the rhinovirus. In this case, we decided that if they were a contact of a confirmed case of the novel entero and also were pan-entero positive, it was quite likely that they did have this novel enterovirus, and that gives you a much higher secondary attack rate of around 30%. And we also looked at the serial interval, and you can see the distribution here for that novel enterovirus. So what did we learn from these 2 incidents? Firstly, what went well? So I think the protocols and questionnaires, we've managed to adapt them pretty quickly for both incidents, sometimes as quickly as within 48 hours. And that's despite enterovirus being quite a different scenario to where we've tested FFX previously. And that involved working very closely with the subject matter experts in this area and adapting the questionnaires accordingly. We had some successes in the data collection. I think the SNAP survey tool that I showed earlier worked well and was used both by the health protection teams and the central FFX team, and was successful with both. We also had rapid ethical review of the protocols, and they were approved very quickly based on the fact that we'd had previous FFX protocols approved. The sample collection we only collected real samples during the H5N1 incident. There wasn't any testing of the sample collection as part of our pandemic exercise, but we did succeed in collecting samples, as I showed, as part of that H5N1 incident for the case and all of the contacts. And we've since put a stock of kits into place. Data sharing has been reasonably successful as well. We have data sharing agreements as part of the Pegasus exercise put in place with the devolved administrations and with the modelling groups. And the data analysis has been done rapidly, and SIT reps produced out of that have fed into the incidents. We continue to still have further areas for development. So as part of the H5N1 incident, the community samples relied on HPT arrangements to collect those samples, which worked fairly well in this particular incident, but are not necessarily in place in all regions across the country. We also had samples that were collected in hospital because the index case was admitted to hospital, as was one of the contacts. And this was actually done as part of another study protocol that we have for novel pathogens in hospital, and that led to some coordination challenges with that study. And there are ongoing challenges with transport of samples. So we don't have a clear sort of direction on whether couriering is essential. And if we do courier every sample that's taken as part of the FFX study, that does have very significant cost implications. I think we calculated for Pegasus that it would be about around £3 million just for the sample transport. There are also conflicts in place with the public health management to some extent as well. For example, the main guidance for both of these incidents didn't include any asymptomatic testing of contacts, whereas that's really critical for an FFX study. And FFX wasn't really integrated into the public health management guidance documents or the standard operating procedures used by the local teams. So it's kind of still viewed as a separate study and not integral to public health management. And we also didn't have guidance on management of asymptomatic cases. And of course, you would expect to identify some asymptomatic cases as part of the FFX study and potentially through other surveillance systems as well. I mentioned that the hospital study, there are several parallel studies that we have plans in place for as part of a novel emerging pathogen. And this does create some issues in that we tend to have several studies that are trying to recruit the same patients. We have ongoing challenges with incorporating FFX data into the public health management system. So as I mentioned, that's one of the disadvantages of the data collection tool that we have, that it's not integrated into the SIMS system that health protection teams use. And from the Pegasus exercise, the way it worked, most of the cases are likely to have been hospitalized cases. So wouldn't necessarily have provided us with that useful information on transmission dynamics. So to summarize, in each of the scenarios that we've used FFX, it's been challenging and resource intensive, but the findings are crucial for informing public health management guidance and outbreak modeling. And the FFX study should be seen as an integral part of early public health management of an emerging pathogen, and not a nice to have add-on. I think the regular testing of FFX in smaller incidents and in exercises does provide us with continuous lessons. We're still learning a lot each time we do it, and it does facilitate this regular adaptation and I think improvement in the processes each time we run it. I'll stop there and hand back to you, Nikki, but happy to take any questions. Thanks.
Thanks so much, Jamie. Thanks for the really interesting presentation. Having been involved in the FFX during COVID in the UK, it was really interesting to hear some of the developments since, and I think you provided some really useful insights with the two incidents since. So thank you very much. I'm conscious of the time. There is a question in the Q&A, if you wouldn't mind looking at it, Jamie, and if anyone else has any questions to Jamie, please pop it in the Q&A box, and hopefully at the end we may have some time to do some more questions as well. I will pass over to Dr. Islam now for her presentation. Thank you. Over to you, Farzana.
Okay, well, thanks, Nikki. So very good afternoon and good morning, everyone. So this is Dr. Farzana from Hamdard Institute of Medical Sciences and Research, HIMSR, New Delhi, India. So before I start my presentation, I would like to extend my heartfelt gratitude to the WHO headquarters and WHO regional office, CRO, country office, to the HIMSR administration, and to my co-investigators. So today we are going to explain and narrate it is about the WHO Unity Network, adapting and exercising the household transmission investigation unity protocol for influenza and RSV among the residents of Delhi, India. What we are actually proposing to carry out in next 2 months. Next, Nikki. So a little brief about the background. So as we all know, the Unity study provides a standardized framework for targeted investigations, enhanced surveillance and rapid assessment for factors like transmissibility, population immunity, and risk groups to support the pandemic preparedness. During COVID-19, as we all have witnessed, Unity protocols are very instrumental in understanding transmission dynamics and infection prevalence and vaccine effectiveness. Hamdard Institute of Medical Sciences and Research is premier medical teaching institute and teaching and research institute under Jamia Hamdard University, New Delhi, India. And we have a established site network of field practice areas and trained surveillance teams that facilitate rapid community-based investigations. So HIMSR already served as one of the active WHO Unity sites during the COVID-19 pandemic, implementing multiple Unity protocols. So our experience, what we did in the previous pandemic, HIMSR was one of the successful site. So we carried out three Unity protocols during the COVID-19. It was household transmission, which was a case ascertained study, and health facility transmission, which was the prospective cohort study, and COVID-19 vaccine effectiveness study, which was a randomized control trial, along with ICMR and WHO. And the key outcomes of all those three protocols were that we collected around 1,541 nasal swabs and samples, and serology samples of almost 934, and healthcare workers, we enrolled 192, and out of all those three studies, we generated 3 publications. So now we are proposing now I just want to explain how we transitioned from the Unity protocol from COVID-19 to the WHO Unity Regional CR network. So we received the invite from WHO to participate in the global network, and followed by that, CRO had meetings with nominated institutions. And then we started discussion and finalization of the TOR and the concept note. And then finally, HIMSR signed the TOR with WHO regarding to be a part of the Unity network, Unity study network. And then on March, when we were asked that what we are going to propose for the coming interpandemic period, so we propose that we will be doing one household transmission investigation protocol on influenza and RSV, and another we propose that we'll be doing one meta-analysis on the burden of influenza. And then we also attended the training from the Global Influenza Surveillance Response System. And then finally, by the end of this the September, we finalized the protocol and refinement and finalized. So this is, we had a ceremonial by involving the highest HIMSR management during the signing of TOR with WHO. So this is one of the picture where our dean is standing, Professor Sunil Kohli, on my left, and my colleagues from HIMSR and HIMSR administration in my right. So what we proposed, HIMSR proposed that we will be doing one primary research study, which is household transmission investigation on influenza A, influenza B, and RSV of the residents of Delhi, where we are going to estimate the household secondary attack rates and the transmission dynamics. We'll be looking into that, and also the demographic, clinical, behavioral, and the environmental risk factors. And the second activity what we have planned is that we'll be doing the meta-analysis to see the burden of influenza among the healthcare workers in low and middle income countries, and along with the incidence, hospitalizations, mortality, and economic burden. And by November 2025, we propose that we will be able to submit the report of our pilot study. We are doing this as a pilot study because I am coming to that, and we'll be able to submit a report of the meta-analysis. So why did we select influenza and RSV for this particular unity study? What we have proposed, and we'll be doing it in next 2 months, because now as it is the October, we have enough evidence that there are an increasing number of cases reported by various institutions. Even the Indian Council of Medical Research has reported that the flu cases and the H3N2 and the RSV cases are on rise. In Delhi specifically, there is a surge of flu, and there are recommendations from the other public health experts, that this kind of surge has to be studied. And this is exactly in alignment with the WHO country office and the CRO guidance. And we have our strengths. HIMSR has its own institutional strengths, because we had already done the household transmission protocol study during the COVID-19, and also we have a suitable field practice area where we can do the studies in a very short interval. Next, please. So the overall, previous slide, please. So the overall aim of this particular study and the framework is that we are going to study the transmission dynamics of influenza and RSV in the household settings. And we have developed a framework where we want to explain. I just want to explain this particular framework where we are telling that the transmission is happening among the households, like either the index case, when the index case get infected, then because of the close contact of the contacts, and because our settings, because as you all know, the population in our country is quite large, and also the population density of Delhi, and particularly the field practice areas where we'll be conducting the study, they're very densely populated, though there are very maximum chances of spreading the infection from the cases to the contacts because of the overcrowding, and also because of at the individual level, there are because of the close contacts, sharing of the room, toilets, and utensils. So there is a very possible connection of transmission amongst the household members. Next, please. So what are our challenges? There are some when we were finalizing this protocol. So we have some challenges, and along with that, we have some opportunities also, but I'm going to explain, because we have finalized the protocol in last month only, and we have a very tight timeline that we have to complete the study within this the WHO biennium closure by mid-November. So we have a budget constraints, because the WHO is supporting us with the catalytic support from WHO. And also we have requested our institution, HIMSR, to co-fund the activities so that we can start rapidly, so that we can complete the activities within November. And human resource also we have started looking for, and we have already recruited, and we are we will be doing the training and other activities. Other challenges we faced during the FANSA approval, and that was expedited, and also the TSA formalities, everything we did it in a very expedited form. And also we requested and also we achieved the ethical approval from HIMSR IC along with the WHO CRO IC ethics approval. And then we have also technical adaptation of the original WHO Unity protocol. And for this particular study, what we are going to do in the next 2 months, we have adapted and we have customized, and then we will be operationalize this context, and which I am going to discuss in my later slides. So how we have adapted this particular protocol and how we are going to exercise. So this is just a brief, and I'll be explaining in my subsequent slide. So title, we have kept the title, the household transmission investigation and associated risk factors for influenza A, influenza B, and RSV virus infection among the residents of Delhi, India. And the scope of the, as it was mentioned in the original Unity protocol, generic pathogen X, typically a new or a re-emerging respiratory pathogen. And what HIMSR's adaptation is influenza A, influenza B, and respiratory RSV virus. Why? As I already explained in the rationale, that there is this surge of influenza cases in Delhi and the neighboring states of Delhi. And it will be a prospective guess at a certain study of the household transmission and their contacts. Next, please. So in the original WHO Unity protocol, the primary objectives was to provide estimates of transmissibility and severity. And in HIMSR's adaptation, we are keeping it as it is because it has been mentioned as pathogen X, and we are doing the secondary infection rate of influenza A, B, and RSV. And also we'll be looking into the secondary clinical attack rate as a proxy measure of influenza A, B, and RSV. Even again, we are also going to see the severity of the cases of and the symptomatic and asymptomatic proportions of all the cases, and preliminary case and infection, hospitalization, or fatality ratios. All those things will be looking after as it is mentioned in the Unity protocol. So it is doable in this limited time period and achievable. So we have not actually we have not done any changes from the original protocol in terms of only primary objectives. Second, please. So in the secondary objectives, it is mentioned that will be to ascertain the serial interval, duration of viral shedding, and other possible routes of transmission, severity, and advanced related objectives. But within this particular time frame and with all the other constraints like budget and HR, and so we are, for this particular study that what we will be completing within this November, we are not doing that. We will not be able to do that secondary objectives. So in terms of study design and population recruitment, so we will be, as this will be a pilot project, it will be considered as a very pilot, a very small project. So index cases in the pilot phase will be recruited from the laboratory database of HIMSR and HISRS hospital. And as it is mentioned, it has to be through a national line listing and initial case registers, because HIMSR is one of the reporting site to the National Integrated Health Information Portal. So we are already reporting all the cases of all the type of cases. So we can take our cases from the HIMSR database, and then we will be following those cases to the community, and we will be doing the contact tracings, and we'll be doing the test of all the contacts as well. So eligibility of testing, it was proposed in the Unity protocol that the method to testing of all ILA cases for this particular study, we will not take all the cases, only the category C That means the severe cases and the category B, the cases with high risk with symptoms. And these categories has been has been guided by the Ministry of Health and Family Welfare, because the ILI cases is a part of reporting site to the ministry. We are supposed to report all the cases like category A, B, and C. So we are only taking the category C and B for this particular study. Sample size, we are very to complete this study within this particular time frame, and for all the resource and budget and constraints, we are limiting our study sample only to the 5 index cases, and they are all household contacts. Next, please. So this is the case investigation algorithm and the data collection tools. The Unity protocol, everything is, we have modified little bit, because form A is for the cases and form B are for the contacts, and form C will be there for the as a symptom diary. So we will be keeping all the forms, but only the days of follow-up we will be limiting, because it is in the original Unity protocol, we need to follow up cases and contacts till 28 days. But as we are supposed to complete this particular study within a particular time frame, so we will be doing the follow-up of the cases and control till 7 days, but we will be doing the symptom diary of all those cases and follow-up till the 1 month period. Next, please. So lab methods, it was mentioned that use of PCR and virus isolation and other validated methods. In HIMSR's adaptation, what we are going to do, we'll be doing the PCR assay with gene expert system for detection and differentiation of all influenza A, B, and RSV. And because it is available in it is an accredited facility, it is a medical institute where we have all the departments, and it is an accredited and national accreditation we have, and we have trained manpower. And as I mentioned in the previous slide also, so we will be taking the nasal sample as it is mentioned in the Unity protocol, like all the samples should be taken on day 1, 2 until 7, day 1, day 4, day 6, 7, and 9. But in this particular adaptation, we are taking sample on day 1 and day 7, and blood and serum sample we are not doing, but we will be doing the symptom diary for till the 14 days. Next, please. So when we're talking about the analysis plan, so we will be doing the descriptive analysis as it is mentioned in the Unity protocol about descriptive analysis of the severity, clinical spectrum, and the course of the diseases. Statistical analysis, as the sample size will be very small, so but at the same time we'll do the analysis. We'll be doing the secondary attack rate, hospitalization, fatality rate, and according to the socio-demographic factors, and we'll try to estimate all the risk factors. And other complex analysis not planned for this particular current study, and also the genomic analysis is also not planned for this particular current study. Next, please. So we have received the ethics approval from CRO and also the HIMSR ethics committee, and we will, from all the participants, will be taking informed consent, and we'll be explaining everything with the objectives in the local language, that is Hindi, and copies of the participant information form will be issued to them, and full consent will be taken, and the purpose of the investigation will be explained in their local language. Next, please. So way forward, what we are planning in the next phase, like during this interpandemic phase, we'll strengthen and expand our network and collaboration of HIMSR with premier other institutes of our country, and enhance our institutional capacity and workforce skills. We'll sustain the surveillance and operational research on respiratory pathogens. And if there is any pandemic in future, we'll strengthen the preparedness and rapid response mechanism, implement relevant WHO unity protocol based on emerging disease context. And with all those together, these efforts will aim to build a resilient framework for timely and evidence-based public health action. Next, please. So we are proposing that for our future studies, we propose that we will be working closely with either medical college and hospitals who had already worked in COVID-19 household transmissions. So these are the list of various medical colleges all over the country, and we propose that they will be our satellite sites under HIMSR for the household transmission studies, unity protocol. Next, please. So lessons, what we learned after doing the unity protocols. Like unity protocols are extremely useful with high quality content and scientific credibility. The use of unity protocols for different settings are very relevant to our national context as well. They are adaptable to local epidemiology and emerging situations. And whenever we are trying to seek WHO CRO ethics approval or the institutional, as because it is an unity protocol, that process is expedited. The network and manpower used in the COVID-19 studies have really acted as a ready reckoner for the present study, and that will be very useful for any further heads to start with the protocol implementation. And given the availability of time and budget and ready manpower, it be helpful in implementing all the relevant objectives, other for whatever we will be keeping this like the secondary and the advanced objectives in the protocols in our future studies. And because of the WHO headquarters, CRO and WHO India support, they provided the technical confidence, so we would be able to adapt the protocol in our local specific for this particular study. So I just want to briefly mention here the progress so far about this particular adapted protocol of the unity what we are going to start in next few days. So adapted protocol is finalized and approved. Both the ethics committee approval we received. HIMSR funded has been approved, and funding from the WHO will be received in next 10 days. PCR testing kits have already been we have already received in our microbiology department. We have recruited the manpower. The training of the manpower is scheduled on 16th October, and the study implementation will be initiated by 16th October after the training of the study staff. And we hope that we'll be able to complete the study by 31st of October. And by 22nd November, I hope we are very hopeful that we'll be able to complete the data analysis, report writing, manuscript, everything, and we'll be able to submit. So that was from my side, and I would like to acknowledge WHO headquarters, WHO CRO, WHO India, our HIMSR management, the CEO, Dr. G.N. Ghazi, and Dean, Dr. Musharraf Hussain, for their support and guidance, our Department of Microbiology, Medicine and Pediatrics, and District Health Administration. Thank you.
Thank you so much, Dr. Farzana. That was a really interesting presentation, and thank you for taking us through your plans to exercise the household transmission protocol. And we very much look forward to hearing your findings and learning from the exercise. We are unfortunately at time. I just want to open the floor for any rapid questions before we close the meeting. If you have any quick questions, please put up your hand. I see there's been a few answered in the chat, which is great. No, if not, we'll close the meeting just to say thank you very much for joining today and your participation. A huge thank you to our two speakers, Jamie and Dr. Farzana. We can hopefully continue the conversation. A reminder to join the Unity Studies community of practice on the WHO Hive platform. I will send out a reminder of those details. Hopefully this will be a really useful platform for us to continue the conversations. And if any other sites are interested in presenting at the next webinar, please do get in touch. And likewise, if there are any other suggestions for the next webinar or thoughts on the topic for that, please also get in touch. Otherwise, thank you very much for joining. I see a hand, Ahmad. Please go ahead.
Sorry for coming in very late. Actually, questions not on the presentations, they were very excellent and of course very clear. This is, in the year 2026, I am Dr. Mohammed from WHO Country Office India. So in year 2026 in the biennium, if we wish to select new sites for Unity Network, can that be done, or whatever we have selected is enough?
Yeah, I think we would certainly be up for discussing if there are any potential new sites. Yes, it's certainly not closed. We are still open to recruiting new sites, but would be happy to discuss further.
Okay. Thank you very much for the clarification.
Okay. Otherwise, we'll close the call. Thank you very much for everyone for joining, and I hope to speak to you again soon.